and welcome. I'm Corey Robinson from JFK Partners, and on behalf of the Title V MCH program and JFK Partners, I'd like to welcome you to the Maternal Child Health Education Series, given that it's April. Today's topic is autism, and this has become an annual event in the MCH series. We have about 140 registered. We're expecting about 30 people here at the live site and the rest joining online. We're not at 30 people here, but maybe some will come in. We are recording today's event and we'll archive it on the JFK Partners website along with the other webinars in this series. Following the webinar, you'll receive a link requesting an evaluation. You may request a certificate of attendance in the evaluation. Web participants can ask questions via the chat box. Please be sure to mute your video and microphones. For those here in the room, please use the microphone we bring you to ask your questions so those online can also hear them. So we have 4 presentations today, 2 fairly brief initially, and then 2 talking about projects that were funded through the Maternal Child Health Bureau, HRSA. So we're going to lead off hearing from Tiffany White, who's at Colorado Department of Public Health and Environment. She has assumed being PI on the Autism and Developmental Disabilities Monitoring Network. We had initially hoped in scheduling this that the 2014 autism data would be released by now, and so we could share that with you. Unfortunately, it's gotten held up and it's due out a week from tomorrow, and we'll actually be able to begin talking about some of the results next Thursday. So there certainly will be some announcements coming out from CDPHE regarding the 2014 data. This is the data that has consistently brought us the expected numbers of people with autism nationwide. And while it varies from site to site, that 1 in 68 number, which we've been using for a while, comes from this data. So with that, I'll turn it over to Tiffany to share with us what the ADAM network does. So do I have to mute myself?
Good morning. Can everyone hear me okay?
Yep.
Great. Thank you for the introduction. And as Dr. Robinson said, my name is Tiffany White, and I am the co-principal investigator for the Colorado Autism and Developmental Disabilities Monitoring Network. As she had mentioned, we had intended to present the most recent CDC data regarding the prevalence of autism collected during the 2014 surveillance year, but due to the delay being released, my presentation will focus on a review of the Autism and Developmental Disabilities Monitoring Network that I will refer to as ADAM for the remainder of the presentation. I will also discuss ADAM network changes that were made for the 2014 surveillance year and describe how ADAM data can be used. Autism spectrum disorder, also referred to as ASD, is a developmental condition characterized by challenges with social communication and interactions, highly focused interest, and/or restricted or repetitive behaviors. As a spectrum disorder, there's a wide range of symptoms, challenges, and strengths that are unique to each person with autism. Therefore, a person's level of functioning depends on the severity and combination of the symptoms. The ADAM Network is a collaborative group of programs that was established in 2000 and funded by the CDC to estimate the number of 8-year-old children with ASD residing in multiple communities throughout the United States. The network is considered the standard for setting ASD prevalence estimates in the United States. Colorado has participated in the ADAM Network since 2002, and the Colorado ADAM Project is a joint collaboration between the Colorado Department of Public Health and Environment and JFK Partners at the University of Colorado Anschutz Medical Campus. The goals of the ADAM network are to obtain as complete a count as possible of the number of 8-year-old children with ASD, provide information on the characteristics of children with ASD, including gender, race and ethnicity, intellectual ability, and age of evaluation and diagnosis. The network also strives to determine whether ASD is more common in some groups, for example, among boys versus girls, or among white children versus Black or Hispanic children. Also to identify changes in ASD over time, and in general to better understand the impact of ASD and related conditions on children, families, and communities in the United States. The ADAM network uses multi-site, multiple source, records-based surveillance methods that have remained as consistent as possible over time. ADAM is an active surveillance system with a two-step process. In phase 1, trained abstractors review and abstract records from sources in the community that educate, diagnose, treat, and/or provide services to children with developmental disabilities. The screening process does not solely rely on a clinician diagnosis of ASD, but also includes the abstraction of records for children with documented behaviors that are consistent with ASD. In the second phase of the study, compiled data from records meeting requirements for abstraction are reviewed by trained clinicians to determine ASD case status. A child is considered to meet the ADAM surveillance case definition for ASD if he or she displays behaviors as described on one or more evaluations, consistent with the DSM-IV text revision diagnostic criteria for autistic disorder, pervasive developmental disorder not otherwise specified, or Asperger disorder. Inclusion of the case does not depend on the presence of an existing ASD diagnosis or classification in child's record, although this information is considered by the clinician reviewers when determining the final ASD case status. For both phases, 10% of records are reviewed by a second abstractor or clinician to monitor accuracy and consistency in the methods. The ADAM network made some changes for the 2014 surveillance year compared to previous years. 2014 is the first surveillance year to use an ASD case definition based on DSM-V diagnostic criteria, in addition to that based on DSM-IV text revision criteria. Within the ADAM network, approximately 81% of children who were reviewed using the DSM-IV text revision criteria were also reviewed based on the DSM-V criteria. Now, although the ASD prevalence estimates for 2014 will be solely based on the DSM-IV text revision case definition, ASD counts for 2014 will be presented and compared for children meeting the DSM-IV text revision and/or the DSM-V case definitions. And this information will be found in the MMWR publication that Dr. Robinson was mentioning earlier. Also new for 2014, the Early ADAM network, which is a subset of the ADAM network, tracked ASD among 4-year-olds in areas of Arizona, Colorado, Missouri, New Jersey, North Carolina, and Wisconsin. Specific to the Colorado ADAM group for the 2014 surveillance year was the addition of a 4th educational source, which contributed to a significant increase in the number of educational records available for review for both 4- and 8-year-old children. And this map is just showing you all the current ADAM network sites throughout the United States. And in all, there's a total of 11 ADAM network sites that contributed to the estimated number of 8-year-old children with ASD during the 2014 surveillance year. Of the 11 sites, a limited number also provided estimates of the number of 4-year-old children with ASD and children with other developmental disabilities, such as cerebral palsy, intellectual disability, hearing loss, and vision impairment. In Colorado, we conducted surveillance for children with ASD and/or intellectual disability who were either 4 or 8 years of age during the 2014 surveillance year, and we'll be doing the same for the current 2016 surveillance year. The geographic for ASD surveillance in Colorado among 8-year-old children includes the 7-county Denver metropolitan area, which includes the counties of Adams, Arapahoe, Boulder, Broomfield, Denver, Douglas, and Jefferson counties. The monitoring area for 4-year-old children was limited to Denver County for the 2014 surveillance year, and will also be limited to Denver County for the current 2016 surveillance year. A total population of 41,128 children aged 8 years was covered by the Colorado ADAM monitoring area during the 2014 surveillance year. Of the 41,121 8-year-olds, 55% identify as white, non-Hispanic, 7% as Black, non-Hispanic, 33% as Hispanic, 5% as Asian or Pacific Islander, and less than 1% as American, Indian, or Alaska Native. Records from 9 health and 4 educational sources were available for review and abstraction during the 2014 surveillance year. As I mentioned previously, the Colorado ADAM project is a joint collaboration between the Colorado Department of Public Health and Environment and JFK Partners. This surveillance project is very labor intensive and is made possible by the efforts of talented and dedicated public health and clinical staff. Kelly Cast and Dr. Corey Robinson Rosenberg led the project as the co-principal investigators for the 2014 surveillance year. Dr. Robinson has been with the Colorado ADAM project since 2002 and has been instrumental in its continuing success. I took over as the Colorado ADAM co-principal investigator at the Colorado Department of Public Health and Environment in July of 2017, and I look forward to continuing to contribute to the project. Now that you're familiar with what the ADAM network is, I'd like to leave you with suggestions on how ADAM data can be used. Healthcare organizations and school systems can use the data to promote early identification of ASD and lower the age when children are first evaluated for developmental concerns, diagnosed with ASD, and enrolled in community-based support systems. They can also use ADAM data to target outreach to under-identified groups of children, such as girls and Black and Hispanic children, or plan for ASD-related training and service needs. Policymakers and community leaders can use ADAM findings to raise awareness of ASD and develop policies to promote early identification and equity and access to services and support. Researchers can use ADAM data to further justify the need for ASD research and guide future research projects, including investigating why and how ASD affects children differently by sex, race and ethnicity, intellectual ability, and community. I thank you for your time, and please don't hesitate to contact me by email or phone if you'd like more information about the Colorado ADAM project. As Corey mentioned, the ADAM Network MMWR Prevalence Report for the 2014 surveillance year is expected to be published next week on April 27th and can be accessed at www.cdc.gov/MMWR. Thank you.
See how we've hit the 10,000 mark, which is fantastic. But one thing that we've learned over the implementation of the study is that getting a complete trio is actually very hard. So this study will be ongoing. Colorado has contributed 245 trios to this 10,000 at this point, which is why it's a national effort. Do you know, how do I advance this? Arrows.
Click on click there.
Here?
No, just click on the screen. Click there.
Okay. So what we can see, or what we have found in our data from 2000 or up to 2017, was that the average age of diagnosis in our population was between 4 and 4.5. This is a little older than the typical population, or the average population that we see. It could be because they're from a larger sample size, or because this is an online study and available to more participants in a rural setting who might not have had as much access to those early services for diagnosis. So, and then we can see this also plays out in the adults that are enrolled were actually diagnosed at a much later date, which is typical for families, or typical for individuals who were born before the year 2000. In our diagnosis and our sample, you can see this adds up to more than 100%. And so that what that's telling us is that those participating in the study have been diagnosed by more than one professional, usually by a healthcare team or a clinical psychologist involved in there at some point. So we know that we're getting a lot of people who have a true diagnosis of autism there. And then as far as language goes, most of the participants use complex sentences, but almost a quarter of them have more limited language skills. In the SPARK information, it looks like right along with the typical population, that only about 7% have serious complications causing brain injuries. So the number of individuals born prematurely is actually a little bit higher than what we've seen in the literature thus far. But one thing that really jumped out at us when we were talking about this was the associated conditions reported with autism. So these aren't necessarily a surprise, but anytime we can kind of highlight some of these co-occurring conditions that affect individuals with autism where they may need more support, I think is an important piece. So in adults, there's about a third of participants have a diagnosis of depression or anxiety or ADHD. And these are overlapping. People can select more than one, obviously, when they're reporting these. So, and the same in children with autism. There's actually fewer sleep problems reported by parents in this study to date than we would have expected to see. But then the seizure rate is about what we would have expected to see, or excuse me, is lower than what has been reported in some other autism studies. So we think that this piece may be because we aren't getting complete parent report data on that. So all our participants are followed up then after a year if they choose to have additional questionnaires. One thing that we did see is that individuals with autism in our study really haven't had a lot of genetic testing in the past, really only about 20% of them. What has come out of those is mostly families with Fragile X have received that testing. So this will be interesting to see if this kind of continues as a statistic in this year as well. But we do have a big push in the next month or so to enroll about 50 trios if anyone is interested. So we, as I mentioned, we are at 245 of about 10,000. So we'd really like to see Colorado represented a little more in there. So we have upcoming events in Glenwood Springs and Pueblo and Durango. So if anybody is online that knows providers or families that are interested in participating, we would love to meet with them and we can get you more information about that. So with that, I can take any questions about SPARK or any of these results. We can move on.
None online.
Okay.
Any questions?
Thank you.
So what I'd like to do is tell you a little bit about the SALSA trial, which is in the process of testing whether patient navigation improves families' access to evaluation and treatment for autism spectrum disorder, or ASD, and also give you a little bit of the results we have about barriers that families have experienced in trying to obtain early intervention evaluation services, and some of the kinds of things an autism patient navigator can do to help address those barriers. I'll just use the clicker. Most children with ASD are not diagnosed until after age 3 years of age, or possibly even older. And routine screening in primary care does improve early recognition. And that's for that reason, national organizations like the CDC and the American Academy of Pediatrics do recommend screening all children for ASD at 18 months and 24 months. That solves part of the problem because then children do get screened and potentially can get diagnosed, but many of those children who screen positive don't get referrals for evaluation. don't end up undergoing diagnostic evaluation, and then may not engage in services. And that's particularly an issue for minority, foreign-born, less educated, and low-income populations who've been shown to receive referral diagnosis and treatment later and less often. And in fact, some of the data that support that come from the ADAM network that you heard about earlier. Also, families in these populations report that they have less information about how to get care, more problems obtaining care, fewer support services that help them connect to services, and less satisfaction in general with early intervention services. So one way to address the kind of barriers that these families have experienced is potentially through patient navigation. It was originally developed for cancer patients who had a screening positive cancer test and needed help sort of getting through the system. So what these navigators do is help patients who have positive findings through and around system barriers that might, in order to help ensure earlier diagnosis and treatment. It's been tested in some situations for children, in particular improving delivery of preventive care like vaccination, but it's been used most extensively for management of chronic conditions like cancer and diabetes in adults. Had not been tested for improving early identification and treatment of ASD at the time we launched the SALSA study. So SALSA's primary aim is to evaluate whether using an autism patient navigator actually improves families' access to evaluation and treatment for ASD. We also are examining barriers that families identify to successful engagement in the evaluation process and treatment services, identify ways that patient navigation might facilitate families' access to evaluation and services, and we're also going to describe the feasibility of using an autism patient navigation system in a safety net system. So today I have a little bit of data about just these two barriers. As I told you, the trial is still ongoing. We actually just enrolled, we think, our last few patients just last week. So the setting for SALSA study is Denver Community Health Services, which is a safety net system for the city and county of Denver. 90% of the children or more are Medicaid eligible, enrolled in Medicaid, and the vast majority are Hispanic or other minority populations. So Denver Health has implemented routine screening for ASD at the 18 and 24-month well visits using the MCHAT, the Modified Checklist for Autism in Toddlers Revised with Follow-Up, which is a parent report screening tool to identify young children at risk for ASD. And if a child is screened and scores in the low risk range, if they're 18 months, that test should be repeated at 24 months, but otherwise they don't require further evaluation. If they score in the moderate risk range, the MCHAT includes a follow-up interview that explores in more depth the answers that were positive on the initial screen, and if those answers are positive, then that child should be referred for early intervention evaluation and for ASD evaluation. And if the score is in the high-risk range, then they are referred directly without requiring a follow-up interview. The screening to services flow starts with that positive screen, and then, if all goes well, the child is referred for both eligibility determination from educational services, but also a clinical ASD evaluation. And then hopefully they get the school-based evaluation to determine their eligibility for educational services and the autism spectrum disorder evaluation from the clinical services team. And then depending on the results of those, the child has a recommendation for some combination of services. In our study, we included children who were 16 to 30 months of age and resident in Denver County, who were seen for a well visit at a Denver Health primary care clinic and scored at least 3 on the initial MCHAT. So some children were randomized with a high-risk score and some with a moderate score who still needed to have an MCHAT follow-up to see whether they required referral. We did obviously exclude children who already had a diagnosis of ASD since they didn't require evaluation. So all those children that were MCHOP positive, lived in Denver City and County, were randomly assigned to the intervention or the control group. And then the Autism Patient Navigator contacted intervention group children who scored high enough to need referral for early intervention evaluation and offered navigation assistance. And she also offered assistance to families who were referred, even if it wasn't for their MCHET score. So the outcomes we're looking at are the receipt of diagnostic evaluation. Did they get it at all? Did they, how old were they and how early? The initiation of early intervention services, did that happen at all? How old were they? How soon after screening? Barriers to evaluation and services experienced by parents, which is what I'll present today, and parent and staff perceptions about the Patient Navigator program. So I'm just really going to talk now about these preliminary results on barriers identified by families. Those were collected through a semi-structured telephone interview with the family by the Autism Patient Navigator, who used that interview to find out what barriers the families might experience and identify the assistance that they may need. So that was done twice at an intake interview when they first consented to navigation, and then a second time if they had made it through the evaluation process and had an individualized family service plan to identify any additional barriers they might perceive to initiating services. If there were, and those responses were coded onto a data collection form, and the navigator also identified additional barriers during the course of navigation that then were also recorded. And the unique barriers were then tabulated and categorized. So the results I'm going to present are preliminary because, again, as I said, we actually are still contacting a few more patients who were randomized who we haven't yet enrolled. So there were a total of 45 families who actually were eligible for navigation contact. That is, they met all our inclusion criteria, plus they were referred for early intervention for diagnostic evaluation. Of those, just under half consented to participation. As I said, there's a few who are still in contact in progress. A small number refused navigation. But about a third, the navigator wasn't able to contact at all. And in some cases, that involved as many as 7 different telephone messages, telephone calls, a letter, occasionally email, as well as home visits in some cases. So families just were not reachable by the navigator. So among these consented, again, I have not all of those because some of those are still in progress. So I'll present, again, preliminary results about barriers that families identified. Among those that we've have been through the process, the group that consented to navigation looks just like the population at Denver Health in terms of insurance status and race and ethnicity. More than half identified Spanish as their native language, and most of those indicated they were most comfortable receiving new information in Spanish. The families experienced a lot of different barriers, on average 4.5 different barriers to obtaining a diagnostic evaluation. Some families said they didn't foresee any barriers at all. Some had just a long laundry list of different kinds of barriers that they perceived or that were identified subsequently. So I'll talk about some of those. The most important barrier was scheduling. It was that more than 80% just had difficulty scheduling an appointment for evaluation. There were issues of having trouble contacting early intervention services, or early intervention services would contact them. They only did 3 calls, and then the child's referral gets dropped if they don't reach the family, and then the family would have to obtain a new referral. Sometimes the appointments got canceled. Sometimes the families forgot to go. They couldn't get off work. So this was a problem for the majority. And actually, among the Spanish speakers, it was a problem for 100%. Informational needs were also important. There were all kinds of things that the families just didn't really understand. And this, of course, was families who had been screened, identified by their provider, and referred, but they often didn't really understand what the MCHAT was, why they had it, what the results meant. They didn't know what autism was. They didn't know why they were being referred, how to get an evaluation, what early intervention was, what services they offered. So there was just a real gap in the communication that they had received when they had that screening test. And again, oops, shoot. Almost messed that up. And again, the native Spanish speakers had more informational needs. The majority of those families had informational needs. More sort of practical and logistical barriers were identified by some, around a quarter or so. Transportation needs were an issue, difficulty getting to the facility for evaluation, needing bus fare or taxi vouchers. Medical needs were a problem for some families where the child or another family member had health concerns that the family valued higher, felt that they really needed to deal with those problems, and they just couldn't really deal with the child's need for a ASD evaluation. And then insurance needs. It was often not communicated to the family that there was no charge to them for getting an evaluation, and so they were worried that they couldn't afford the evaluation. Other barriers were less common. There were beliefs and attitudes around health or healthcare system that created a barrier for the family in terms of their willingness to have the evaluation, and they went in both directions. Some were the child's going to improve on their own, there's no point in getting the evaluation. Some were, there's nothing I can do about autism, so what's the point of knowing if they have the diagnosis? They were concerned about the stigma attached to the condition, concerned that they wouldn't get an evaluation that was appropriate because of their citizenship or their race or ethnicity. Physical needs were not that common, but childcare needs or families just had pressing needs like the need for housing, clothing, and food that really kept them from focusing on evaluation. Only a couple families said they needed interpretation and translation, although I think that became more of a problem later in their process. Once families actually had an evaluation and the child was diagnosed with ASD, there were somewhat different barriers to initiating and engaging in services. And this is based on very small numbers, I will say. So, so take these with a grain of salt. But the two problems that really arose at that point were insurance and financial concerns and language and literacy needs. Again, concerns about being able to pay for evaluation and services, citizenship issues, and maybe not being eligible. And then language and literacy needs arose because less about translation, but the materials that they received after their evaluations, they were not able to actually read because either they couldn't read at all or they were just written at too high a level for the family's literacy. So there's lots of different ways the navigator was able to help these families to overcome the barriers that arose. One of the things she spent the most time on was contacting the early intervention program on behalf of the family to schedule and to reschedule appointments that had been canceled or that the families had missed. She also, when the early intervention program had done their 3 contacts and dropped the family, she would go back to Denver Health and ensure the new referral was sent to get the child back into the system so that they could schedule an appointment. She also helped the families to keep track of their appointments and sometimes join the evaluation in the family's home. She, as part of our training program, we gave the navigator education about the tests, the procedures, the referral, the early intervention services, and about autism. So she was able to provide education to the family to address all their informational needs. Transportation needs, whether it was if they had private transportation, just helping with maps and parking information, or helping with bus fare or taxi vouchers, or communicating with the taxi service on behalf of the family. educating them about the fact that they didn't need insurance coverage to have the evaluation, helping with applications, and then addressing the other kinds of needs as well, providing resources, additional education, going with the families so that they felt confident about the evaluation process, helping with interpretation, providing support after diagnosis. The other thing a navigator can do, and that our navigator did, was also sort of work on a system basis to try to improve the process so that maybe less navigation was needed. She did quite a few group trainings for providers and staff, and also shadowed some providers and staff and gave individual feedback about screening and the autism referral process, about the MCHAT and the need to do the follow-up interview if the child scored in the moderate range, information about what happened. A lot of providers at Denver Health felt it was sort of a black box. They sent off a referral and never heard anything after that. So giving them information about the process that happened afterwards and what the family could expect. And she also established ongoing communication with Rocky Mountain Human Services to sort of facilitate the scheduling process. I thought what I would do, do I have time? Okay. I thought what I would do would just be to tell you a case study about a family. So you can see some of the kinds of barriers that arise for a family to try to get a diagnosis of ASD and have their child have appropriate treatment. So this was a 34-year-old Hispanic, Spanish-speaking mother with 2 sons. And the younger son was seen for an 18-month well-child visit. So at the 18-month visit, the child did not get the ASD screen. However, he did have an ages and stages questionnaire, which indicated a problem. So he was referred to early intervention services for evaluation. Now, because it didn't say anything about ASD, that wasn't done. So just the educational eligibility determination. And the child was determined to be eligible for speech therapy, and so started in speech therapy. So the family came back for the 24-month visit, and mom was quite concerned because the child was not making progress. At that time, the MCHAT was administered, scored in the moderate range, but the follow-up interview was not done. The child was again referred to early intervention for reevaluation, but the referral did not specify ASD evaluation. So if it doesn't specify that, it doesn't happen. So that was a point where the child was randomized to SALSA, and the patient navigator looked at the medical records, saw the child had the positive screen, no follow-up interview, no referral for ASD evaluation. She contacted the family, and the mother was very keen to have her help because she was so concerned about her child's lack of progress. So she was having difficulty scheduling for the new evaluation because she had trouble with taking off work. So she asked for the navigator to help, and the navigator initiated a 3-way call to schedule a visit where she also could participate with the mom. This was a solely Spanish-speaking mother, so she needed some help for that as well. So at the home visit, the navigator asked the evaluator whether they would evaluate the child for ASD, and they said no because it hadn't been requested. However, if the family requests it, they are required to offer that evaluation. So the navigator encouraged the mother to request that, and that was arranged. So finally, at 30 months, the child had an evaluation from the clinical services team. So this is a year after problems were identified, and at that time, the child was diagnosed with ASD. So the case manager and evaluator at that visit wanted to explain what the child was going to need, but the interpreter who had been arranged by the early intervention services didn't show. So the navigator, who was bilingual, was able to translate for them and help the mother understand what they were recommending. The mom afterwards didn't really understand exactly what the services were and what they were for, so the navigator spoke with her by phone to go through all the different procedures and services and explain what they were and what they were for. So eventually the mom got into early intervention ASD specific services and then began to make very good progress and was very happy with how her son was doing. Then the son turned 3, became eligible for public school services. So a meeting was set up at DPS. The mom called the navigator, even though we were supposed to stop navigating at 36 months because she had transportation issues. The navigator arranged a taxi voucher, but when the mom tried to call the cab company, nobody spoke Spanish. She wasn't able to communicate with them. She called the navigator who helped arrange transportation to the visit, and she went ahead and attended that visit. And she also stayed through the visit so she could help the mom get a cab going home. And the other issue that arose in this visit was that the evaluator or the school evaluator looked at the child and said, "This child doesn't look like he has ASD." So anyway, that was one example. So you can see that there are many, many, many barriers that can occur that prevent a child from getting a timely diagnosis and into services. This particular family had barriers in terms of screening, referral, evaluation, and services. So in conclusion, low-income children, families whose children screen positive for ASD experience multiple different barriers to accessing diagnostic evaluation and services, particularly we found related to scheduling and informational needs. A navigator is able to provide a wide range of assistance to help guide those families through and around these important barriers to timely diagnosis and treatment. We've included some resources at the end of the slides for more information. El Grupo Vida is a collaborator on this study, and they have a support group for people with disabilities and their families. If anyone is interested in our patient navigation resource guide that we're using for this study, we'd be happy to share that. And here's our team, including here at the university, Denver Health, Rocky Mountain Human Services, and El Grupo Vida. And also, I acknowledge our funders. Thank you. Any questions?
So the group that
We're supposed to use the mic.
the comparison group, what's happening with them?
So in this study, the control group is getting no intervention, and the way we're determining our outcomes will be through linkage of Denver Health and Rocky Mountain Human Services records. So we'll be able to see whether the children in the group that was randomized to receive navigation were more likely to receive an evaluation or were evaluated earlier, because we'll have information on both the control children and the intervention children.
And we have a question from online. How is it determined if a family is eligible for a navigator?
So in this study, a family was eligible for navigation if they received a referral, if they had an initial MCHAT-R screen and then received a referral to Rocky Mountain Human Services. The other, the navigator, if the child had the initial screen and didn't receive a referral, had an initial screen positive, didn't have the MCHAT follow-up and didn't have the referral, she would reach out to the family and the provider to try to make that happen. But she wouldn't navigate if they didn't have a referral, because there wouldn't be anything to navigate, but she would try to get the referral if possible.
So when the patients were identified for this study, was the type of Medicaid looked at, like Colorado Open Medicaid versus Denver Health Medicaid Choice?
We actually have that information, but I haven't analyzed it in any way. It's a small number of Medicaid choices, I recall. I haven't looked at that, but we could certainly look at it. I don't think so many have a Medicaid choice that it's going to be evaluatable. I think there was a question. I thought I saw it on here.
Such important work, thank you. How long after the IFSP meeting is the second interview done? How should we contact the project to receive an application?
Okay, so maybe what I can do for the second question is I could add contact information to the slides and repost them. Would that be helpful? Okay. And then the first question. So an attempt was made to contact the family as soon as the IFSP meeting was held. And a lot of times the navigator went to that meeting as well, just as soon as possible.
Can you repeat that question again?
Oh, sorry. There were two questions. One was how to obtain the patient navigation guide, and we said that we would repost these slides with contact information on them. And the second question was how soon after the IFSP was developed did the navigator contact the family, and the response was as soon as possible. And in some cases, the navigator had attended that meeting and so was able to look at that right away, but usually as soon as possible.
Thanks so much, Chris. All right, now it's my pleasure to introduce our last presenter of the morning, Eric Moody, assistant professor here of psychiatry, has been associated with JFK for a number of years now, and he applied for and obtained a R40 project from Maternal Child Health Bureau that looked specifically at a parent support paradigm for families. So Eric, while the project's been wrapped up for about 2 years now, there's still interest in parent mentoring, and Eric can share the findings from the project and possibly next steps.
Thank you, Corey. So this is actually a good kind of follow-up to what Carolyn was talking about, because the R40 that I got is really looking at the next step after diagnosis. So this is a program that we call the Colorado Parent Mentorship Program, and it focuses on the first year after diagnosis. It actually, in some ways, is similar to the model that Carolyn used in terms of family navigators. We use parent mentors, and I'll talk about what that means. But the point that I'm going to try to make in my talk is that, and I think Carolyn's case study really kind of typifies that, in some ways, the secret sauce here to all of the families that we work with, giving them the best chance for success, is really thinking beyond the child, him or herself, but really looking at the whole family unit. So that's what I'm going to talk with you about. So I'm a social psychologist. I love context. I think it's really important to keep this in mind as we talk about what we tried to do and the findings that we have, because it really drove what we tried to accomplish. So we all know this now, the 1 in 68 number, maybe it'll change in a week, we don't know. But tied to that, there really is a very high public health burden. You can see that the average lifetime cost of all services associated with autism is between 1.4 and 2.4 million. It's a big range, but that's a lot of money. And this is actually reduced from estimates about 10 years ago. It was up at 3.2 million. And the impact that that has on the family itself is that the cost of behavioral services ranges on average per year about $40,000 to $60,000. I don't know about you, but I don't have an extra 40 to 60 grand laying around, and most of these families don't either. Associated with that, the cost of medical expenses, so not the behavioral treatment, but the medical expenses themselves, on average, and this was a study of Medicaid, were 6 times higher than children without ASD. So really, the whole idea is that this is just a big, big public health issue that we need to be cognizant of. For the family itself, though, it's really important to understand what they're facing. And again, as Carolyn alluded to, there is a lot of structural challenges, social structural challenges that they face as they try to figure out how am I going to make this work? We all know about long wait lists. Here at our clinics, they're extremely long. That's not unique. There are long wait lists all over the place, and people are actively trying to figure out ways to reduce that wait time. But it's just kind of a problem of scale. We just don't have enough providers. There's not enough funding, both in terms of reimbursement for providers themselves, as well as for people to be able to pay for these services. Doing a multidisciplinary evaluation is not cheap for anyone. And as a result, when we started this work, the estimate was that it took about, after a diagnosis, it took on average parents 5 months to find and access the first service, which is, this is a long time. Typically when you go to a physician for, say, some other kind of a condition, like a sinus infection, you start treatment right there. People have to navigate a lot, as we heard, in order to make it work. Diving into the parent's perspective yet a little bit more, think about what they're faced with. So autism as a condition is a little bit unique. There is no standard of care. And in fact, there are well over 100, if not hundreds, of different specific types of services that are designed to impact the core symptoms of autism. Despite that, and this is from AHRQ reports, I think there was a Cochrane review as well, they talk about, there's only 2 with a modest evidence base, and those are applied behavior analysis, ABA, and early start Denver model, which has a component of ABA as well. And it's not to say that there aren't other things out there that work, it's just that the evidence base is still emerging. And so in many ways, this is the Wild West in terms of interventions. We don't know how to individualize care very well. We don't know how to say, you know, Mrs. Smith, your son Bobby is presenting this way, therefore you should make sure that X, Y, or Z happens, and we would expect these outcomes. A lot of clinicians simply say, we're going to do our best. We're going to use the kind of standard 20 to 25 hours of ABA per week recommendation because we can, and it's a good recommendation, and we hope to see outcomes, and if we don't, we'll keep trying. But that's a really vague response for parents. And so imagine what they do. They get on the internet, they look, they talk to other parents, and if they have over 100 different models to choose from, why not try something else? So on average, parents are trying between 4 and 5 different types of treatment or interventions per year. And the scary thing is some have been shown to be harmful. The most notable example is chelation. There was a period where that was very popular when people believed that heavy metals were the cause of autism, and children died. So this kind of wild, crazy world that parents are faced with is not without danger. And so it's really no wonder then that when they're faced with these structural challenges, it sets the stage for some a high level of challenge and burden. And so it's not surprising that when you talk with folks, their quality of life is low.
Can you define ABA?
Applied behavior analysis. It was developed, originally called the Lovaas model, and it's really an operant conditioning kind of a behavioral approach. It's really based on positive behavioral supports. A behavior occurs and you reinforce it. If you get a behavior you don't like, you ignore it. Don't punish it, you just ignore it. So it's a behavioral intervention. And again, it's no wonder then that the overall burden is really very high. So quality of life is low. And what's interesting is we've got a ton of data on this. And I've talked with a lot of parents in a lot of different studies now. They're basically saying to me, yeah, we get it. We're all stressed. I don't want to hear any more about the level of burden anymore. Fix this, make it better for me. So we need to figure out something to do with these unpredictable outcomes, something to do with the very complex systems of care. The other things that they're facing are extreme isolation. They often report that they figure out who their real friends are very quickly, because the ones that aren't, they leave. Once they find out that their child has autism, they don't come over for play dates anymore. They talk about challenges with their spouses, with their in-laws, with their other children, with community organizations who won't help them. They talk about anxiety, depression, all sorts of things. And so interestingly, some new work that's coming out is showing that there's an increased rate of adverse childhood events in families who have children with autism relative to both typically developing controls as well as the broader category of children and youth with special health care needs. So it's really kind of, at least at this point, it seems like a really dire kind of situation. So at this point, I think it's important for you to know some of the assumptions that I make in my work, and it in many ways preceded this research, but it was really solidified by doing this. These assumptions guide everything that I do now. The first one is that raising children is hard. I mean, if you have a child, if you're a parent, you know this. Staying up late because of ear infections and all these other things, getting them to school and dressed in the morning and brushing teeth, that in and of itself is hard. And you add autism on top of that from all of these different things that we just talked about, it's an added set of challenges, okay? But it's still fundamentally parenting. It's really nothing radically different in terms of what parents want. They still want their kids to have a high quality of life, to get an education, if they can, get a job, if they can be productive members of society and included, that's what they ultimately want. It's fundamentally the same thing, okay? And so here's the good news. Despite the fact that the systems of care are so crazy, there's just gobs of research that has shown that social support is one of the most important predictors of well-being and adjustment in people who have parents who have typically developing children, but especially parents who have kids with autism. And this is the interesting thing. It has nothing to do with the degree of symptoms, and it doesn't have to do with real actual levels of support either. It's really mostly about perceived social support. This is the key. The parents have to believe that they're getting the support that they need. When you do that, their sense of competency increases and risk for mental health, like things like depression and anxiety goes down. So that's the good news. This gets me to my second and third assumptions, which are, we know that it's hard to be a parent and autism makes things more challenging, but it's also really important that everybody that is involved in that child and that family's lives, they are there to help. And I think sometimes parents misplace that, especially when you're faced with an IEP meeting, which is a school team meeting, where things can get very contentious. Everybody there, the systems are all designed to help. Despite this complexity, everybody's there for the same reason. But here's the problem. Help, whatever that is actually a very subjective thing. Help means different things to different people. And in terms of the medical model, what help really means is that around evidence-based practices. And I think that's completely appropriate. We want to be doing things that we know work, that are effective in reducing the problems that we know exist clinically. Things like ABA and ESDM and behavioral training and social skills, PT, OT, speech, psychology, all of these things are really, really important. But there's a bit of a problem. And I describe this in terms of what's known as Maslow's hammer. This is attributed to Abraham Maslow, but other people have said this as well, that if the only tool that you have is a hammer, you tend to see every problem as a nail. And I think this sets the stage for there to be kind of a disconnect between clinical service, what the goals, the clinical goals are, and what parents really want in terms of the outcomes that mean the most to them. And let me give you an example of just this problem. I was at a talk a couple of years ago. One of the faculty here in the Department of Pediatrics was talking about nutrition in kids with autism and how, it is important to make sure that kids get fed well. And one of the parents in the audience got up and said, this is great, but my life is a shambles. How am I supposed, you're throwing this on top of all the other things that I have to do. And she really eloquently described how this is fine to have this as a clinical goal, but it does not meet the needs that I have right now. And sitting next to me was a clinician, and she whispered in my ear, she goes, doesn't this mom get it? If she would just do what we tell her to do, the problems would get better. And I was like, oh, yeah, I guess that's true, but you're missing the point. What the parent really needs and what the parent really wants doesn't match with the clinical objectives. So I think it's really incumbent on us to pay attention to that. And that's where we got the kind of the kernel, the idea of what we're talking about now, which is the Colorado Parent Mentoring Program. So as I said, this is a kind of a nice follow-up to Carolyn's study where we're looking at the first year post-diagnosis. And we partnered with 3 clinics, Developmental Pediatrics and the JFK Clinic, Rocky Mountain Human Services, and those with the 3, yeah. So the idea here was we wanted to, much like a parent navigator or patient navigator, we wanted to arm parents that were in this period right after diagnosis with a lot of information so that they could be their child's best advocate. We based it on the family empowerment model, which assumes that if you empower parents, if you empower families with the right information, they will be able to get through all those systems much more effectively. And so what we had hypothesized is when we provide these types of supports, parents will have a better quality of life. They will have greater access to care. The latency between diagnosis and onset of treatments would be reduced, but it got a little bit more complicated. So let me talk to you about the program itself. It's really founded on providing 2 types of information. First, informational support, or 2 types of support. Informational support, which is really just things you need to know. Facts, figures, what's the difference between an IEP and a 504. All of the bits of data that are critical in understanding these very complex systems of care. When we were developing this, though, our partners, which included Family Voices and the Autism Society, several others, they all said over and over, you can give people information until you're blue in the face, but that's not going to be enough. You also need to really emotionally support them as well because they're in a time of crisis. The first year after diagnosis is really a chaotic period, and so don't assume that if you throw information at them, that's going to get the job done. You need to support them more broadly. And so from those 2 types of support, we developed the Colorado Parent Mentoring Program to have 3 different components, which are just described here: individualized action planning, navigation training, and then ongoing parent-to-parent mentoring. So I'm going to talk about each one of these briefly. The first is an individualized action plan meeting. So what happens here is the parent whose child is newly diagnosed within the last 3 months at one of our clinics, they get referred to us. He or she joins us here at JFK Partners, along with 2 of our staff, and these didn't have to be health professionals. We often had people who either had an MSW, a Master's in Social Work, or family counseling degrees, but we also did this with our research associates well, who had a bachelor's degree. So there was 2 of us, and then also a trained parent mentor. I'll come back to them in just a minute. We sit down with them and they bring us this big packet of information that they get from one of our clinics or the referring clinic with all the list of recommendations. And it almost always starts with 20 to 25 hours of ABA, and they don't know what ABA is, and they're worried about how am I going to get 20 to 25 hours if I don't know what it is. I've got to work. How am I going to do this? And that they kind of shut off from all the rest of the recommendations. We get that beforehand. We read it, but we really don't get too involved in that. We sit down with this blank sheet of paper. And we start off by saying, Mr. and Mrs. Smith, it's great to be here with you. Tell us about your child. Tell us about Bobby. And they talked for a little bit and they said, okay, that's really helpful. Tell me what you would like to have happen. What are you trying to accomplish in your life right now with your child and your family? And we'll often refer to those list of recommendations. But, you know, for example, one of the things that came up a lot is toilet training. Geez, he's 8. Why can't he just use the toilet? It's driving us crazy. And we went through a really, we trained all the people that did this to use a really open-ended questioning technique, kind of like motivational interviewing, to elicit what they want. And sometimes it's something as simple as, I just wish he would use the toilet. Then we took the next step and said, well, what have you got in your toolkit right now so that we can figure out what you need to do to get to that goal? Part of what we did in this process, though, is sometimes we got them back to reality. You can't go from no toileting to complete toileting overnight. There's steps in between. So maybe the first step is to alert mom when wet. Let's just start with things that we can do something about. And then, it's kind of hard to see, figure out what have you got in your resource toolkit right now. So it could be a psychologist that you're working with. Why don't you talk about that person with including that in their clinical goals? Or maybe you've got a nanny that helps out a few hours a week, and you can talk with him or her to really start building up some supports within the home. And then we make some really concrete action steps so that the parents have, instead of just this big summary, 20-page summary, they know the next thing that they need to do. That's very, very actionable. And we do that until we, they don't have to come up with 5, but they might. And so it could be things like stimming or eye contact. And same thing, we talk about what are their specific goals that they want to accomplish, what resources do they have, and what are you going to do to get there. One of the things that's really critical is that we always talk about the family too. And this is, again, getting back to this whole idea of the whole family context. It's really, really important. And let me give you an example. This came from the very first action planning meeting that we did. It was a father of a lovely young boy with autism. And so he and his wife were just desperately trying to make this work. He worked nights, mom worked days. They basically had half an hour at the morning and the night where they could, they met each other in the home. They basically passed information, and then, basically it was just sort of a pass of the new shift was taking over. And he said, it's killing us. I mean, he said, I don't know if we're going to make it. I don't know how much longer I can do this. And so we talked with him about, well, what do you need to do with your wife in order to start feeling like you can get through? He said, we just need a break. He said, I don't know how we can do this. We talked for about 10 minutes, and he said, when I quit my last job, they did give me this, it was a 5-day cruise for free. I mean, I've got the tickets, it's just sitting there. I said, well, that's a resource. But he said, how am I going to leave my son? He said, well, do you have family that knows your child well? Oh yeah, my mother and father-in-law. There you go. So the idea was that we found things that he already had. And I mean, I don't know if they ultimately did anything with it or not. But what's cool about this meeting is that we have that parent mentor that's always right there. And often as parents are talking about all of these challenges, they ignore the professionals. We're irrelevant. They look to the mentor and they say, has that happened to you? And there's almost that immediate connection that parents, then they start talking amongst themselves. And quite often, we just sort of fade into the background, which is pretty darn cool. But at the end of this, they've got this toolkit or action sheet that they can do something with. We don't monitor it. It's all up to them. We don't want anybody to feel like if they don't accomplish this, they've failed, because life circumstances change. But it's something that they can take with them. And one of the things that's really important to know is this isn't just talking for the sake of talking. We base this on National Academy of Sciences recommendations on what makes a good intervention. So we train them on this so that they at least know what to be looking for as they're seeking services. The next step is the navigation training. We did this in partnership with Family Voices. This was really just a data dump to talk about all those things. Medicaid, insurance, IEPs, school systems, 504, IDEA, ABA. I mean, the list goes on and on. It took 3 hours. This was done right after the action planning, so at least they had a framework of what they wanted to accomplish, and it could fit on top of this navigation training. The cool thing about it is it's just information. You can put this in any format to be effective. This is all just adult learning. We've been developing these into online modules for quite some time. I think we're getting there. But it's great that it can be really adapted to whatever the context is to be effective. Back to the mentor. We trained these people pretty heavily. So these were all parents. We call them veteran parents. They had to have a child that was at least 2 years past diagnosis. We went through a 2-day training with them. The first day was really just that data dump that we just talked about. We went into a ton of detail, and they all reported that that was some of the best information that they had. Even though they were, in some ways, seasoned professionals in navigating these systems, there's a lot of nuance. And so this really formal training helped them tremendously. Day 2 was a lot more emotional, and we wanted to prepare them for that emotional side of dealing with people in crisis. And part of that was them processing their own grief. We called it grief, but it could be anger, it could be depression. It could be whatever they want to call it. It could be positive emotions too, but we wanted them to be prepared that the other people that they're going to be interacting with could be in active grief. And so we talked about that. We also went through a lot of really active training techniques to teach them what it means to be a mentor. We did video examples, role playing. They all hated the role playing, but they said it was really important for them to know that it's going to be hard. And we did pre and post test for all of that, and then gave them a certificate at the end. But back to that action planning meeting, it was really important that we matched people as closely as we could on the things that mattered to them. These were some of the stuff that they cared about: geography, race, ethnicity, religion, parenting style. We had one attachment parenting mom. This is the parents, you saw that Time cover with a 5-year-old breastfeeding. She was really concerned that she was going to be judged. And we're like, you know what? We've trained our parents to be as non-biased as possible, and she actually got a lot from the program. So we only had a cohort of 20 mentors, so we couldn't accommodate every request, but we did our best. And then after those 2 meetings, that mentor stuck with the other parent for at least 6 months. And we asked that they check in at least monthly through whatever mean they wanted. It could be phone, it could be Skype, it could be a coffee shop, it could be in their backyard over a beer. We didn't really care, but we wanted to make sure it happened. We filled out a monitoring form after that. And then in terms of the research, it was a randomized controlled trial with a 6-month active period, and it was a waitlist control design as well. So our waitlist group, after 6 months, they got the full intervention. We used a lot of different measures, and I'll talk about some of these. The FACES is the Family Adaptability and Cohesion Scale, the Parenting Sense of Competence Scale, the Family Quality of Life, Family Impact, and then qualitative interviewing. I won't get into the mentee demographics too much, except to say it's a very different sample than what Carolyn had. Ours was really middle-class white women. We had a few men, we had a few other ethnicities represented, but not much. This is our consort table, and we had pretty similar groups after all was said and done. Interestingly, though, we had really high interest initially. 162 people were screened. It was even higher that people that expressed interest, but 74 individuals were lost to follow-up before we could randomize them. And I think that's a testament to just how chaotic this period in their life is. As for findings, first of all, people really described high satisfaction with the program. They talked about how much they loved it, how important it was. Interestingly, there was no impact on stress or the whole family impact. And we were surprised at first, but it makes sense if you think about it. All of that chaos that I just described, we can't change that. It is just a chaotic period. Interestingly, we also didn't change service utilization, which we expected, but again, it makes sense because those systems of care are just so complicated. What we did find is that most people relied on IDEA-based funding, speech and OT primarily, and that there was a really substantial drop in the summer. In terms of positive findings, so there were 2 that I think are tremendously interesting. First is the Family Quality of Life Scale. They have a subscale called Satisfaction with Disability-Related Supports. We used linear mixed modeling with a baseline as a control for certain variables. I don't want to get into too much of the stats of it, but if you look up at the top, that's our primary model. And what it said was that there's an interaction between the intervention itself and time. So what we did is we broke that into 2 groups. We stratified it. So the one, do I point with this? Here we go. Oh, they won't see that online. Okay, so I'll just start with the bottom group. This is the waitlist group. Interestingly, they did not see any change in their level of satisfaction with care, but interestingly, their satisfaction went down as child's score, SRS scores, which is a measure of their autism symptoms, went up. So the more autism symptoms, the less satisfaction they had. But for the active group, SRS scores did not matter. I mean, they really did not matter, but time in the study actually contributed to their satisfaction. So, and I think that was really cool. It doesn't matter how severely impacted the child is. By giving them this intervention, they are more satisfied with with whatever they get, and it could be all kinds of different things. The other thing that was interesting is the Family Adaptability and Cohesion Scale. This is a scale of what's called family rigidity. Same sort of thing, we saw that interaction. If you look at the active group, there was no, and I'm going to describe what this measure is in just a minute because it's kind of complicated, but there was no effect there, but there was an effect for the waitlist group. So over time, what this means is that they got more rigid. So what does this scale really represent? If you look, the FACES is what's called a circumplex scale, a circumplex model, which is this really complex diagram. Rigidity is really just that lower bar of black space at the bottom. And what it means is that the higher the score on rigidity, the more chaotic the family is in terms of they demand things a certain way. And so if you go back here, people that aren't given this intervention are actually becoming more rigid and saying that this is the way I have to have my family. People that are not on the wait list, who are actively getting this intervention, they can deal with things in a much more fluid and dynamic way. Just for the sake of time, I won't get into our qualitative findings. All that suffice to say, people really described qualitatively to us that they felt more emotionally capable of coping with what they confronted. They also felt like they knew the systems better. They felt like they could do this. And I like this last one. It gave me the knowledge to figure out where to go next. So they really did describe being more empowered. So in conclusion, what we think this means is that if you support families, if they are kind of the focus of that informational and emotional support, their satisfaction with what they need to get through goes up. It prevents family rigidity, which could help long-term outcomes. It improves emotional quality of life and sense of confidence, but it's not about child characteristics, and it's not about the amount or type of care that they get. That remains static, which is really important. Despite all that, their life is going to remain stressful. We can't just wave a wand and everything gets better, although I wish we could. And so what does this really mean? So what? What's the big deal? I think it says that providing care directly to kids is important, and it's not the only thing that we should care about. Supporting families directly has measurable impact on how they are able to cope and ultimately how they access healthcare overall. And I think that really comports with the triple aim. Remember that the legs of triple aim is really making sure that people get what they want. Their satisfaction matters. And so in conclusion, I think this is really the secret sauce. One of the things that's really missing in order for people to feel like they have successfully been able to raise their child with autism and get them to where they want them to be. A productive member of society who has a job and a place to live. All of these things, helping the family get there, that's really one of the most important things that we can do as people that work with families that have children with autism. So a little behind time, but these are our partners and the obligatory funding statement. So that's it. Thanks, everyone.